You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Be sure to follow the podcast on your favorite app so that you never miss an episode. Today, we're exploring the future of imaging, intelligence, and equity with Dr. Effie Andrikopoulou, Associate Professor of Medicine at the University of Washington and Medical Director of the Echocardiography Lab at Harborview Medical Center. Dr. Andrikopoulou brings a rare blend of clinical, operational, and technological expertise. Training in medicine at Thomas Jefferson, cardiology at UAB, advanced cardiovascular imaging at Brigham and Women's, and an MBA to tie it all together. She's a leader in cardio-oncology and a nationally recognized expert in cardiovascular imaging. But what really sets her apart is how she approaches artificial intelligence, not as a replacement, but as a force multiplier for human wisdom. In this conversation, we dive into what she calls collaborative intelligence, exploring how AI is already being used in echo labs, what remains inherently human in imaging, and how we can design equitable, patient-centered AI from the ground up.
Quality supplies make a difference. At EDM Medical Solutions, we support over 2,000 healthcare facilities across the U.S. with high-quality medical products built for real clinical needs. From ultrasound imaging accessories to surgical instruments and everyday disposables, our portfolio spans women's health, men's health, and the operating room. We've spent over 35 years helping practices deliver safe, efficient, and cost-effective patient care, with the personal support only a family-owned company can provide. Explore our full range of solutions today at us.edm-imaging.com.
Today, we're stepping into a frontier where cardiology, artificial intelligence, and equity in care converge. Our guest is Dr. Effie Andrikopoulou, Associate Professor of Medicine at the University of Washington and Medical Director of the Echocardiography Lab at Harborview Medical Center. She trained at institutions across the U.S., internal medicine at Thomas Jefferson, cardiology at UAB, and advanced cardiovascular imaging at Brigham and Women's Hospital in Boston. She also holds an MBA from UAB. Dr. Andrikopoulou is an expert in cardiovascular imaging and a recognized leader in cardio-oncology. But what sets her apart is her passion for integrating artificial intelligence, what she often calls collaborative intelligence, into clinical workflows. Her work not only focuses on improving efficiency, but on ensuring high-quality, equitable care across diverse populations. She's been honored with awards like the AHA Women in Cardiology Training Award for Excellence and the Rising Stars in Healthcare in Alabama. She's also part of the growing movement of clinicians shaping the ethical, equitable application of AI in medicine. Dr. Andrikopoulou, welcome. It's a privilege to have you on the show.
Hi, Emmanuel. Thank you so much for the invitation. I'm so excited and looking forward to having a very productive and thoughtful conversation about how we can integrate responsible AI into our everyday lives and our workflows inside and outside of our echo labs.
Let's start with the narrative around AI. It's often positioned as a disruptor, but the reality might be more nuanced, right? Is artificial intelligence truly disrupting cardiovascular imaging, or is it actually reinforcing and refining what expert clinicians already do best?
This is a fantastic question, and I'm glad we're starting with this to set the stage right for the conversation. I would say it's both, just like most things in life. Nothing is all black or all white. Same thing with artificial intelligence or AI, especially in cardiovascular imaging, which is at the intersection of cardiology and radiology, the top two adapters of FDA-approved AI tools and services. So AI in cardiovascular imaging is both a disruptor and a stabilizer. And that's where the real value of AI lies, is in that duality exactly. It's disrupting how we do things. That means we can use AI, and we are using it, to automate measurements, automate segmentations, and in some studies even to do some preliminary triaging of which studies are abnormal and need to be interpreted and looked at right away. Um, but it also stabilizes our why behind all of this. It can reinforce consistency, it can reinforce quality and scalability. And so for seasoned clinicians and echocardiographers and sonographers, AI um, can act and already acts because there's already labs that are using AI and have it as part of their daily workflow. It acts like a force multiplier. It can increase throughput and it can free a lot of cognitive bandwidth of sonographers and clinicians to understand more deeply and to make more nuanced decision making. I do want to make one comment though. It's essential that we don't mix speed that AI can offer with wisdom that humans offer.
Right.
And that's especially important in lower resource or non-specialized settings. Um, that's where we can and should be using AI, but definitely with a lot of mindful and rigorous human oversight to make sure that we don't normalize or allow errors to happen or miss outliers in imaging, especially, which only a very trained and well seasoned eye can catch. So, yes to responsible AI and yes to augmenting, but not replacing our clinical and human judgment.
Absolutely. And you make such an important point when you talk about having wisdom and how we use it, right? Because that is some of the fears. Even some of our guests on this show have expressed how they've encountered those fears in the field when they're talking about AI integration. Is this going to replace us? And also, will the quality go down? And there's serious risk to that, of course, if it wouldn't be controlled. But that's why the human supervision is so important, right?
Exactly, 100% right. That's why it's important to very mindfully and responsibly pair the two. Pair the AI with the human in the loop. And not just in the loop, but honestly, the human in the center. We still need to use AI as a tool and not as a means in and of itself, but rather as a tool to really ensure that our care is patient centered. And that means understanding both the strengths, the very real strengths of AI, like we said, automation, standardization, standardizing quality, but at the same time, acknowledging the limitations, which is the output of any AI algorithm is only going to be as good as the data that we put into it.
Right.
And that's where very, very rigorous oversight and governance of AI and monitoring of AI all along the journey of adoption and integration and post deployment monitoring is critical.
Right. And you also make a good point of how you discuss the process of the deployment of AI, because I think with AI being in the news so much, even in healthcare news, of course, it makes it seem like these things are just being deployed at large, in mass without any oversight. But there is a process and a way of doing it right. So just really great points that you brought up. Now, talking more about the human aspect, right, which we already kind of got into. I mean, echocardiography remains highly operator dependent, and algorithms right now, they might identify things like wall motion or they'll calculate EF, but the interpretation of nuanced findings and how those findings inform clinical care still relies on clinical judgment. So, in your view, what aspects of echo remain inherently human, things that even the best AI trained or best trained AI tools, I should say, can't replicate, at least not yet?
Absolutely. And Emmanuel, you're hitting the spot on. Echo is more than just images and measurements. Echo is really a dynamic storytelling in real time. The thing that got me passionate and got me to love echocardiography and cardiovascular imaging is how I realized that I can learn so much about another individual, be that the patient or maybe a healthy individual getting a study done for some other reason, but how it allows us to learn so much about that person without even seeing them. So each echo tells a story in real time. And that's what Echo teaches us is, and that AI hasn't mastered yet, is the art of putting everything together, of recognizing the subtle findings in the context of a patient's evolving physiology and clinical presentation, and bedside nuance and findings. And it also teaches us, I also say that Echo teaches us humility. Uh, a lot of times, what looks like a trivial finding on screen may carry profound clinical implications. We see that every day in our labs. Any one of us who read studies and take care of patients. Um, so that's as far as the clinical everyday life of reading an echo goes. But it's more than that, even from an educational perspective. And that has to do with our cardiology trainees and cardiovascular imaging trainees. Echo is so crucial. It builds foundational spatial reasoning and hemodynamic understanding of cardiovascular physiology. And these are the skills that every cardiologist needs to manage any kind of patient, from shock resuscitation, undifferentiated shock, to heart failure management, to ACS, acute coronary syndrome, amyloid heart disease, and the list goes on and on. And so, even though AI can assist with interpretation, we still need that human looking at the echo and bringing everything together along with the patient's clinical history, the presentation, the symptoms, the patient's preferences and wishes on what they would like to have done. That's where really the value of being human lies, and that's essential.
Absolutely. We really do have to continue emphasizing that as technology advances, that basic element of the human, the clinician themselves, is just so integral, right? Now, one major shift that we're also seeing is more and more decentralization. You'll see things like pocket devices, AI assisted reads. There's even programs now that are assisting non specialists using AI on how to perform scans. And so, with miniaturized devices and AI enabled imaging, do you think Echo is ready to be decentralized at scale? Or do you think that sometimes we might be moving a little too fast without the necessary infrastructure?
Yes. Um, I will say that it seems to me, also working clinically, that we are at an inflection point. Um, Small devices and AI together are making point of care echo more accessible than ever, right? All we need is our cell phone, and we can plug in a probe and we can start taking pictures and saving them. And that's great, but it's exactly what you mentioned, Emmanuel. Decentralization and democratization of echo should not be done without deliberate infrastructure.
Right.
Otherwise, um, we are creating this a really um, dangerous setup for us,
Right.
because we can create more noise than clarity. And so, values like quality assurance, standardization, and planned and well-designed integration into clinical workflows should be non-negotiable. We cannot compromise on quality, and we cannot compromise on standardizing protocols, nor should we compromise on smooth integration with the rest of a patient's electronic health record. And um, so that said, as long as these are in place, um, the potential to extend ECHO and decentralize it and extend it beyond the traditional walls of a big hospital, a well-resourced center, or a well-resourced outpatient ECHO lab, that potential, especially in rural or underserved settings and communities, that's incredibly powerful. But we should make sure that we do this, that we design this um, v- very mindfully and rigorously, and based on the values that we just discussed, Otherwise, we risk of fragmenting the system and, like I said, creating more noise than added value.
That makes sense. Now, do you think that the use of that or that increase in democratization of the use of these tools in places like rural settings, it makes sense, right? There's not enough specialists around. Typically, the individuals who live there are not getting that sort of imaging. But what about in a larger health system where there is an echo lab? Do you think that in those cases, it's still a good idea to do that for the sake of being able to see more patients? Or in your opinion, do you think we start to kind of cross the line of maybe we actually are risking going down in quality simply for the sake of perhaps seeing more and more people when you have most labs in our country overwhelmed already by patient volumes? Or do you see it more so as a solution, even in those cases that it's not a rural or underserved area?
Absolutely. This is what our echo lab, and I know a lot of other echo labs in the country right now are struggling with, is how do we meet the rapidly growing demand in both inpatient and outpatient echoes with being constantly understaffed and under-resourced. I know that you guys had a very insightful conversation talking about the challenges that our echo labs are facing in
Yes.
making sure that we meet the growing demands. In general, I'm a half full glass kind of person. So I think this can work. I would never say no to something. I think this can work provided that it's designed thoughtfully. What do I mean by that? As long as let's say that we have a health system, a hospital like ours, and what you're asking me makes me think of a situation where we have our colleagues in the emergency room doing point of care ultrasound, or our critical care colleagues doing point of care ultrasounds. I would say yes to that, provided that we all work together to co-design protocols, and that we all work together to make sure that we provide appropriate training and education to anyone who's going to be expected to perform these studies, and that we also have the system set in place that we all co-create that will allow for us to do continuous quality checks and monitoring of the workflow and the process. And provided that we meet our predefined metrics for quality and for success, then I could see a system like that working even in a well-resourced setting because of the reasons that you mentioned of the growing demands. Like I said, it should be founded though on continuous quality assessment, co-designing the system with all of the stakeholders, having a seat at the table. Uh, at the end of the day, we all want to take excellent care of our patients. So anything that empowers us to do that while also using our resources to the best that we have, and being cost conscious and mindful, then I would say yes to that, provided that we co-design it very, very thoughtfully and responsibly.
If you are high level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Old can high level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Old. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show. So overall, you would say quality assurance and collaboration both are key
Yes.
to successful implementation. Right, that makes sense. Moving on to another point that I think we should discuss, we often hear how AI is closing gaps in healthcare, right? But that promise does come with significant design challenges. What really needs to happen from data collection to deployment to ensure that AI and cardiovascular imaging lives up to that promise of reducing disparities, not reinforcing them?
Yes, I will say that this is something that I feel very passionate about. I do believe that AI can close gaps, but only if we build equity and diversity into the DNA of AI from day one. That means that we have to ensure that we train our AI algorithms on diverse data sets, on data sets that are representative of the community and the population that they're meant to serve and identify. We have to rigorously stress test our AI algorithms for bias, and we have to validate our AI tools in real world, real patient contexts, not just in academic silos, if that makes sense. Um, and also, we must challenge who gets to define how well an algorithm performs.
Hmm.
What I'm trying to say with this is that performance and accuracy of an algorithm looks very different in a tertiary care center as opposed to a safety net hospital. And I've seen this firsthand, having implemented AI both at my previous hospital at University of Alabama in Birmingham, which is the South, versus my current hospital at Harborview, which is in the most urban pocket of Seattle, safety net hospital, underserved urban population. And so true equity requires co-creation and co-design. Because then the question is, okay, how do we ensure equity? It's great to say that we want to build equitable AI algorithms, but how do we do that? So this is done by co-creating, meaning we have to have patients sit at the table when we design the algorithms, not from day one. We have to have the communities that are going to be served by those algorithms and frontline clinicians. This shouldn't be a tech silo, a tech group sitting down and coming up with a solution to a problem that they're not living and being impacted by every day. And then once deployed, AI tools, we have to audit them continuously, just like we do with medications or devices for any side effects, to make sure that post-deployment monitoring in reflects that our algorithm continues to serve our population the way it's meant to. We do have to keep in mind that AI algorithms are a living and breathing organism, and they will change as the data that we feed into it changes. That's why we have to continuously monitor performance of the algorithm following deployment to make sure that it continues to serve us the way it was designed to.
Right. Now, do you think that how do you see different actors in this space? What I mean by that is, what role would you say health systems have or healthcare facilities have versus the role that then our societies have here in the US? And then also universities and researchers. Do you think that we've reached a point where all of these are acting together? And actually, a fourth one would be private firms that are developing these AIs for healthcare. So, between all four parties, do you think we've reached enough collaboration, or do you think that that's actually perhaps one of the biggest barriers to us not having those data sets at this time?
Yes, excellent question. And if I may add, there's another key player that we haven't mentioned, which is the payer, the insurance companies.
Okay. Yeah.
So I would say patients and family members and patient advocates, clinicians, frontline clinicians,
Right.
health tech companies who are going to engineer those algorithms, and payers, and like you said, our communities. We all need to collaborate and say, okay, first of all, what are our needs? What do we need? What is the problem that we need to solve? And then how do we want to solve it? Like all the things that we just discussed: equity, minimizing bias, diversity, uh, being open to different voices.
Mhm.
And then how do we integrate those tools in our systems in a way that doesn't worsen um, clinician burnout? So I will say for the health system specifically, o- one of the priorities for health systems would be how do we integrate these algorithms in a way that ensures smooth operations, both from the administrative backstage side, but on the front line, so that our clinicians and our nurses and our techs and all of our healthcare professionals don't get fatigued more. They don't have to bear an even higher burden of work than we already do. I mean, we all know, I don't know if there's any different with any other of my colleagues, but I always have work to do after hours, over the weekends. It's just work never stops. The last thing that a health system would want is, instead of wanting to improve patient care and ensure high quality, equitable patient care, to do that at the expense of clinician burnout. So for the health system, I think it's going to be extremely essential, important to make sure that they have both of those criteria in mind when they select which AI tool they're going to work with and implement in the health system.
Makes a lot of sense. Very insightful, the way that you just discussed sort of the relationship between those different stakeholders. There's much more than five, right? There's a whole lot that goes into it and a lot of work that we have to do. Now, let's zoom out and talk about diagnostics in general. As imaging becomes faster and more integrated into care pathways, which is something you kind of already alluded to and mentioned. Some experts have argued that we're moving toward a diagnostics led model of medicine, one where imaging, especially advanced echo, for example, guides care earlier in the process, even before those symptoms arise, right? We can see so much more now. So, do you see us shifting more toward a model where diagnostics drive care more than traditional clinical evaluation? And what are the benefits or risk of that kind of shift, in your opinion, especially as a physician?
What a great question. And I love that we're getting a little broader now. Imaging is definitely evolving from confirmatory or risk stratification testing to more of a predictive compass, like you mentioned, Emmanuel.
Right.
And I would say that shift is exciting. It starts making us shift our paradigm of clinical practice from a reactive to proactive
Mm.
mindset. So instead of using imaging to identify established disease or markers of disease, um, we can use it to help us predict what might happen in the future. And we see that, right, in preventive cardiology, cancer therapeutics, and population health. Advanced imaging is now showing that it can guide care even before symptoms arise, but we must tread carefully.
Mm.
Um, where I see the advantages are a diagnostics-led model can streamline clinical triaging. It can personalize diagnosis, which also means personalizing management and treatment, and allow for earlier intervention, which we would hope it would translate into better health outcomes.
Right.
Everyone is healthier. But there's a but here.
Mm.
But without thoughtful governance, it could also lead to overtesting, incidentalomas, and unnecessary patient anxiety, especially now that our patients all have access to the entire electronic health record.
Right.
I can't tell you how many times I've started getting questions in my inbox from patients asking for trivial findings on their echo that don't really bear any clinical significance.
Right.
And so imaging should be central to this paradigm shift, yes, but it shouldn't be dominant in care pathways. The future is not, the way I see it, is that it's not that our future is imaging versus clinical acumen.
Okay.
It's imaging with clinical wisdom, and it's imaging guided by the right patient-centered, patient-first incentives and oversight and patient values. As long as we do that, I think we'll be at a great position to change the way we practice medicine. Instead of practicing disease management, to
Right.
practice promoting health.
Yes, it's very exciting. It really seems to be like a key move towards more and more prevention, right? Which is, of course, a goal, like you said. Now, do you think that so there could be a risk, do you think, of increased costs if it's not implemented carefully? Or do you think that with the way that AI is moving in imaging, perhaps, maybe we won't have an increased cost? Or do you think that no, that there could be the risk there if we emphasize diagnostic imaging so much that then everyone's just being imaged?
Exactly. And that's a very, very timely question, especially with the very real financial hardships that all health systems face.
Mhm.
Um, it goes back, I think, to what we discussed about ensuring that it's not that a health system isn't imaging dominant.
Okay.
Is ensuring that imaging is part of a clinical care pathway that is founded on clinical acumen. And it's one piece of the puzzle that hopefully we can use earlier on before having to face all of the downstream effects of deteriorating disease states. And so I think that should have the potential to cut costs, minimize costs from a health system standpoint. Because if that works, and if we make imaging part of a broader clinical care pathway that is not, again, that is not imaging dominant, then the goal would be to keep people outside of the ERs, keep them outside of hospitals and from getting hospitalized. And that will definitely minimize costs. Anything that leads to improved clinical outcomes is bound to correlate with looking good on a P&L, on a financial
Right.
statement.
Right.
There's no question about that. But like I said, we need the frontline clinicians to have a key role when designing those clinical care pathways. The frontline clinicians, the radiologists, our nurses, our techs, all of them coming together to build those clinical care pathways. And then for each one of them to be tailored and customized to the resources available within each healthcare system and each hospital. Not every hospital is the same. So taking into consideration the resources that each system has, then they can deploy these processes.
Right. I mean, the goal is what you said, right? For greater, more enhanced clinical outcomes, a healthier society, really. And so a healthier society is going to lead to a healthier system. So I like how you broke that down, that even if we would be spending a little more on the imaging aspect, right? The idea would be that it reduces that financial burden of all of the diseases that come after. Not just that, people have better lives, of course. That's the main thing of what we're all looking for, right? Is for patients to live longer and healthier. So just really exciting stuff, all the things that you shared. I mean, we could go on and on. I'm sure you have a lot of things that you could share related to that. But I know that you're very busy. So I really do appreciate you, Dr. Andrikopoulou, for coming on the show and giving us such a great insight into the future of echo and this new diagnostics led model of care that truly is transformative. And of course, everything going on with AI. So thank you so much. It's been a pleasure having you on.
Thank you so much, Emmanuel. It was such a pleasure. I had so much fun. Hopefully we get to do this again, and next time we are able to talk about all of the successes of using AI in clinical workflow.
Yes. Thank you.
Thank you.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.